will very much complement Fiona's. I'm a doctor, I'm a family physician, I'm very much steeped in evidence-based medicine. I hold randomised controlled trial as the gold standard for evidence-based medicine. And my research background is that I trained as a qualitative researcher. And so, methodologically, I would call myself a pragmatist, because what I actually do is I ask research questions, and then I have my toolbox to answer the question that I pose. And from that, I take whichever methodological approach, be it phenomenology, be it grounded theory, be it ethnography, be it surveys, be it the full gamut of methodologies to answer the questions that I pose. And particularly I'm interested in designing complex intervention trials to try and improve the breastfeeding rates in the UK and to produce findings that are generalisable internationally. Now in the UK we've got pretty poor breastfeeding rates. We have about 80% of our mothers who initiate breastfeeding, but within the first 2 weeks, 20% have given up. And by about 6 months, you've only got about 10% of women who are giving any breast milk at all, less than 1% who are exclusively breastfeeding at 6 months of age. So it's a real problem in the UK. So I work in the Nursing, Midwifery and Allied Health Professionals Research Unit, and there are just a few leaflets there if anybody's interested, and we're funded by the Scottish Government to undertake high quality research. So an overview. I'm going to give you a little bit of background. Then I'm going to talk about one of the first intervention studies that I did, which used action research methods, which Fiona hasn't covered. And that led to a multi-centre randomised controlled trial of a policy to provide breastfeeding groups across Scotland. And then, for the reasons that will become clear, I'm going to talk about my latest work, which is the Feeding Support Team feasibility trial, which has been published, and we're just waiting now to hear if we've got a really large grant to take this to the full definitive multi-centre randomised controlled trial. So the systematic review evidence tells us that internationally, any additional support increases breastfeeding duration and exclusivity, that complex multi-component trials seem to work better than simple interventions. Education either to mothers or to women, pregnant women, or to health professionals, the systematic review evidence tells us that this is ineffective. It does not change breastfeeding rates. And then a meta-synthesis of all the qualitative research, which Fiona mentioned, this is the equivalent of meta-analysis, where you pool it all together, suggests that person-centred communication style, as opposed to a breastfeeding-centred communication style, seems to be helpful. And so breastfeeding-centred is very much about promoting, and perhaps women can feel a little bit pressurised to breastfeed, and it seems that women don't respond well to that. So that's a summary of the evidence. But the UK seems a little bit different, and we've published this because there have been 9 consecutive randomised controlled trials in the UK that have provided additional support to women, and not one of them has had a significant effect on breastfeeding rates. So what's going on here? There are all things like skin-to-skin after birth you would expect to work. Lay breastfeeding cancers, there's a lot of evidence, certainly from America and Australia, that peer support is effective, but nothing seems to work in the UK. And that includes the trial that I'm going to be talking about, which is a breastfeeding group trial. And that's going to be the focus of the first part of this talk. And it seems that context, which we talked about in Fiona's presentation, seems to determine outcomes. And there's something going on with the unique context, which means that interventions are not generalisable from other countries. And one of the reasons that we discovered behind this is that when you think about the theory of changing women's behaviour, the model, the theoretical model that's been applied, has been really quite linear. So it's a very individualistic model of choosing your behaviour change theory, delivering it as an intervention to the pregnant woman or to the woman who is trying to breastfeed, and anticipating that you'll get the desired behaviour. But in fact, our research suggests that a complex adaptive systems model might be more appropriate, because the individual and their social network, the culture, and the complexity of the interactions between the individual, the environment, the situations that that individual is in, and the behaviour, all interact in a very complex way. And also particularly important for breastfeeding is history. Not just the history for that woman about whether she had a successful feeding experience for her first baby, but also the history of her mother, her sisters, her social network, and her vicarious breastfeeding experience. So here are some of the individual theories of behaviour change that have been applied to not just breastfeeding, but smoking cessation, obesity, alcohol, and it's been a very common paradigm, a very common model across all of the lifestyle health behaviours, and I'm not going to go through them one by one. But one of the arguments that I'm going to make in this talk today is that we need to really embrace a more complex systems approach to changing lifestyle behaviours. So if you compare the individual model and these more complex systems type approaches with the systems approaches, you're looking at the organisational and environmental structures and processes which actually facilitate the desired behaviour. They tend to be more like touch. In the UK at the moment, nudge theory is very popular, which has been adopted from health economists in the United States. So they tend to be broad in their reach. Whereas an individual model, you're very much putting all of the onus, all of the burden on the individual woman to change her behaviour. You're educating her, you're encouraging her, but as a result, some women can feel pressurised. If a woman fails to breastfeed for whatever reason, she can feel very guilty and lose self-esteem. And also, as Fiona's work, which is the ethnographic work on the postnatal wards, women have very little control over the environment that they're in, particularly in hospitals, where staff are very rushed and undergoing all of these rituals that go on in hospitals. And the individual model is often quite intense. We often deliver, say, motivational interviewing techniques or cognitive behavioural therapy, different sort of packages, which are really quite narrow in their reach and very, very focused. And they don't always work. So I'm now going to talk about the Banff and Buchan breastfeeding coaching study, which was my first intervention study, and it came out of my early qualitative work on infant feeding decision making. Banff and Buchan is a very small region in the very northeast of Scotland, quite rural, with fishing communities, including a boat building yard very similar to the sort of boat building yard that you've got here in Split. So some parallels there. And we used action research, which was first described back in the 1950s by a social psychologist called Kurt Lewin. And my next slide will just tell you exactly a little bit more about action research. Also, I used mixed methods, and we set up an antenatal and postnatal peer coaching intervention. So you have actively breastfeeding mothers who meet mothers in pregnancy and talk to them about breastfeeding, and then in a group setting or one-to-one after birth, they help the women to breastfeed. And in the groups, we had professional facilitators, either midwives or health visitors. Health visitors, I don't know whether you have them in Croatia. Have they got another name? So they're in primary care, and they're looking after mothers and infants up to the age of 5 years old. So action research. There are 5 tenets to action research. It's a very bottom-up community development approach. So it's very flexible, it's very iterative, so you're constantly changing the research according to the data that you're collecting. It's responsive to the subjective meanings of everybody involved. So it would, for example, interview the women, it might interview the health visitors, the midwives, the staff, the doctors, to take everybody's perspectives. So some sort of parallels here with ethnography, but really it's an approach that draws from all of the qualitative theories that Fiona talked about. It's a very pragmatic, on-the-ground approach. And it's responsive to the ever-changing, unique context. So it is like a complex, adaptive system, and nothing is fixed. Everything is constantly changing. So the findings from our coaching study was that there was a significant increase in breastfeeding outcomes at 2 weeks. But we delivered this intervention in 4 separate small towns. And in one of the small towns, the breastfeeding rates went down. Why, we thought. And we had conducted qualitative research with the interviews with all of the stakeholders. And we actually found out that the area where the breastfeeding rates went down, there was a single breastfeeding expert. She was a midwife, she was passionate about breastfeeding. She was wonderful in terms of everybody respected her, all the staff respected her as somebody who had got more knowledge about how the breastfeeding physiology, how breastfeeding works, than anybody else in the community. But breastfeeding rates went down in her area. And what we found is that where there was a team approach, where the health visitors and midwives worked more effectively as a team, those are the areas where the breastfeeding rates went up. So that was quite an interesting finding. So I want to look at action research now, because this was quite a novel approach at that stage to designing a complex intervention. What are the advantages over perhaps a more traditional method of designing a randomised controlled trial? Quite often what we do is a little pilot study, and a pilot study is an exact replica of the randomised controlled trial that you plan to undertake. And it either works or it doesn't work, in which case, if it doesn't work, then you basically don't get any grant money for your large, full-scale randomised controlled trial. And the benefit of action research is because we collected this qualitative data, we discovered that actually having one single expert for an area was not the most effective way to deliver a breastfeeding intervention. If we'd done a pilot study, we might have chosen a breastfeeding expert in all 4 areas, in which case our intervention study would have had a null result, and we wouldn't have been able to progress to the next trial. We also found that groups were more popular than one-to-one coaching. Only 14 of the 206 women in our study actually opted for a personal coach, and the coaching as a term was quite unpopular because women felt that they were being pressurised. Coaching was like coaching for swimming or some sport. It was all about success. And the women felt too pressurised by the coaches. The disadvantages of action research in developing an RCT is that we couldn't really work out how much the action research process itself had contributed to the success of the intervention, particularly as it seemed to be coming through quite strongly that teamwork seemed to be an effective part of the intervention in increasing breastfeeding rates. And also we had some problems about data collection methods and replicating them because things were constantly changing, and with an action research approach, everybody has an equal voice. Everybody's perspective is listened to. And one of the problems with the action research, which will become clearer later in this talk, is that you're matching the intervention to, well, in this case it was 4 geographical areas, but one context, and I'll say more about that later. So from this preliminary intervention study, we had some important questions. To what extent did the action research design contribute to the success of the intervention? And how important is maternity care organisation in determining outcomes? The expert approach versus the team partnership model. So I'm now going to talk about the definitive randomised controlled trial. So we were fortunate to get funding from the Scottish Government to do this trial. It was a cluster randomised controlled trial of the clinical and cost effectiveness of a policy to provide breastfeeding groups across Scotland. There are very few randomised controlled trials of government policies, and the government supported us to do this. So we had 14 areas across Scotland, and we randomised 7 of them to set up breastfeeding groups to support their population, and 7 of them were asked not to change their breastfeeding group activity. And we have very good, routinely collected child health data in Scotland. We've been doing this for over 15 years now, and for every mother and baby in Scotland, we know how they were fed at birth, how they were fed at 10 to 14 days, how they were fed at 6 to 8 weeks. So we had our data already collected, which was fantastic for a randomised controlled trial. So we dropped the coaching, because it was unpopular, and one of the things we had to decide was what aspects of the preliminary intervention we fixed and which aspects we left flexible. This is to try and incorporate the action research approach, which we thought was part of the success of the first study. We chose local investigators who were health visitors, and we had multidisciplinary steering groups which met every 4 weeks for reflective practice. So some aspects of the intervention were fixed because with a randomised controlled trial you need to be able to replicate your intervention. It needs to be something that was generalisable, and other areas could be changed according to these steering groups. So here's the trial design with 14 localities. We also have the data on 52 localities that weren't participating. So we had 2 controls. We had the internal control and the external control. And we had matched pairs to match for socio-demographic characteristics. And right from the onset, we hypothesised that the implementation of the trial would be slightly different in all of the areas, and that we would see different outcomes in the 7 intervention areas and in the 7 control areas. So similarly to the preliminary study where one area differed quite substantially from the others. So here's where we bring in the qualitative research. So the underlying philosophy was one of realist philosophy by somebody called Pawson. Realist philosophy is basically quite different from other qualitative approaches. It does tend to use mixed methods. The easiest way to explain this is to think back through history to ancient times, the ancient Greeks, who thought that the world was flat. And that was a very common assumption until Aristotle and then others developed the theory that Earth was actually round. And that was an example of how something can be real and true, but something that cannot be observed with the naked eye. We all go out there and just looking around us, you would think that the Earth was flat. And so it basically argues that you can construct theoretical models that explain the world, reality, without actually being able to observe it. I mean, physics is the classic example where there's an awful lot of realist philosophy. But we were applying this to a randomised controlled trial, and we were informing our approach by grounded theory. And you've heard about that from Fiona. But it isn't really, we can't call it grounded theory because we haven't got a blank slate to start with. What we're taking from the starting point is the systematic reviews of the evidence, and also as a starting point where we've got the hypothesis for the randomised controlled trial. So we've got our hypothesis, the null hypothesis that breastfeeding rates won't make any difference to breastfeeding outcomes that we are actually testing. So this is where our toolbox comes in, because actually what we're doing is we're taking some of the theory from grounded theory to develop an explanatory model, but we're also using ethnographic approaches because during the delivery of a trial we want to observe what's going on. We want to find out the perspectives of the women and the staff delivering the trial, to find out why it's working perhaps in some places and not in others. And so really the methodological approach that I come from is really very eclectic. It takes a little bit from different areas to answer the research questions. And the most important part of this is the prospective embedded mixed method case studies, which was the process evaluation for the trial. With randomised controlled trials, you want to avoid bias. It's really important. So if you're collecting qualitative data, it's very important that you're not interacting with your intervention, interfering with your intervention at all. You don't want any contamination between the intervention arms and the control arms. And also, you basically want to have a prospective approach. To do a trial to find out that it works in some areas and not others, and then afterwards to collect the data, you've got retrospective biases creeping in. So the approach that we advocate is a prospective analysis of the qualitative data. And I'll come back to that and answer any questions if it doesn't become clear when I describe actually what we did and how we did it. So the important thing here is that the case studies were completed prior to knowing the trial outcomes, and our theoretical model to explain the trial outcomes was constructed before we knew the results. So what did we do for these prospective embedded mixed method case studies? Well, we used questionnaires. All women who were initiating breastfeeding, we wanted to know their characteristics. We wanted to know how many breastfeeding groups were set up in each of the areas. We wanted to know how frequently the groups were held. We wanted to know the numbers of women attending the groups, whether they were pregnant or whether it was after birth, how long after birth they attended, and also we wanted to know how many health professionals, how many group facilitators attended. Was there just one expert group facilitator, or did they have a rotation of group facilitators? Did several group facilitators, health visitors and midwives attend the groups? So we collected a lot of quantitative data about who was present in these breastfeeding groups. I have to say that all of our areas managed to set up a minimum of 2 new breastfeeding groups to cover their area, and all of them managed to, well, some of them set up 6 new groups, so they all complied with the trial protocol for delivering the interventions, and there was no problem with that. We did 126 qualitative interviews with women, both women attending groups, but also those not attending groups. We interviewed midwives, health visitors, peer supporters and managers, and we did some focus groups. We very much wanted to see what else was going on in these geographical areas, so we had key informants, and there were 20 of them altogether, and we interviewed them every 6 months to try and find out what was going on that might be interfering with our intervention. And most importantly, we did fly-on-the-wall observations of some groups. So we sat in the background with our notebook and our recorders and recorded what was going on. So there was no significant change in breastfeeding rates at 6 to 8 weeks. And what we found was that in the intervention arm, breastfeeding rates increased in 3 areas, they decreased in 3 areas, and they remained the same in 1 area. So the trial had a negative result. Not what we expected, and obviously it was quite a disappointment to UNICEF and the Baby Friendly Initiative, because those of you who know the World Health Organization and UNICEF state that at step 10, all women should be referred to breastfeeding groups to support breastfeeding. And in the UK, step 10 has now been abolished following the publication of this trial. So, why did the preliminary intervention work and not the trial? And through the qualitative methods in particular, we were able to understand this. So, if you remember, in the preliminary intervention, we used an action research approach. It was my own patch as a GP, as a family physician. I knew that patch really well. The intervention was very well fixed and fitted very well with the context. What we have in my area where I work is we've got 4 small maternity units. But in the big trial, we had far more centralised maternity units. They weren't such rural areas. And whereas in the preliminary intervention, the midwives and the health visitors worked really well as a team, because they were sharing the same premises in these small maternity units, they were bumping into each other in the corridor, they had coffee and lunch together, they were sharing information. In the trial, the midwives and health visitors didn't know each other. Some of the midwives had to travel 20 miles to get to the group, kilometres, say 20, 30 kilometres to get to the group. As a result, the engagement of midwives in the intervention in the preliminary study was high. In the preliminary study, 6 times more pregnant women attended the breastfeeding groups than in the main trial. 4 times more women attended overall after birth, because what happened is that when women went to the groups in pregnancy, all the group members said, "Come back immediately after birth, show us your new baby." But for women who hadn't attended in pregnancy, they didn't actually start attending the groups until their baby was 5 weeks old. And by that time, in the UK, 40% of women have already given up breastfeeding. So they were attending the groups too late. And the reason for that was that because the midwives weren't engaging in groups, so they didn't encourage pregnant women to come to the groups, and it was a cascade process. As I said, there was absolutely no difference between any of the 7 areas in the number of groups that were set up, the number of attenders in the groups. We could not explain the difference in outcomes by the quantitative data on the number of women receiving the intervention. But the prospective mixed method case studies were really illuminating, and I'm going to talk about that now. So this model was created from the qualitative data and some of the quantitative data. It's called a hierarchy of health service needs. And basically at the top, you've got a successful breastfeeding group policy. And you will see that at the top, you've got the reflective action cycles. Very much what we found in the preliminary study, that this midwives and health visitors and women all coming together to actually reflect on the intervention delivery was one of the components that contributed to success. And down at the bottom, under fundamental importance, were the places where the groups were held, whether the midwives and health visitors were in the same place or whether they were 30 kilometres apart, and also the personnel resources and organisational stability. Team and individual attributes were really important. And in all of our areas, there were charismatic individuals who would really reflect on what was going on and be able to run very successful breastfeeding groups that attracted women to them, both pregnant women and breastfeeding mothers. Crucial in the middle here was leadership and management. In the areas that had problems with the places where the breastfeeding groups were being held, staffing levels, teamwork, the managers spent all their time troubleshooting with these bottom layers. In the areas where there were fewer problems at these lower levels and strong leadership, there were the organisational opportunities for multidisciplinary partnership working between women and health professionals that led to these reflective action cycles, and these were the areas where breastfeeding rates went up. So now I'm going to unpick each of those levels and show you the supporting qualitative and quantitative data that enabled us to reach this explanatory model of the breastfeeding outcomes in the 7 areas that delivered the intervention. So if we start off with the bottom tier, in areas where breastfeeding rates went up, a mother said it was easy because it's not very far away. And obviously, I knew it like the back of my hand. It's all done up and nice. And this was a group that was in a very nice new maternity unit with sofas, it had hot drinks, women took home bakes for refreshments. And here in an area where breastfeeding rates went down, the health visitor said about the place where the breastfeeding group was being run, it's got very basic equipment, no comfortable seating. Scotland, well, it's always freezing cold in Scotland, and it was cold, and trying to breastfeed a baby when it's a cold room is very, very challenging. All of these things suggest to women that it's a patch meal service, so that it wasn't being prioritised. So when we analysed the data, we use the framework approach to the data analysis. So what we had is in our rows on a large Excel spreadsheet, we had the key themes that were coming out of the qualitative data. These were the amount of organisational change, staff shortages, low morale and stress amongst the staff, the skill mix, where there was a good collaboration between staff with lots of different skills relevant to supporting breastfeeding, midwife involvement, which we have always mentioned was very important, and then in some areas we had health visitors who did antenatal home visits to try and build this continuity between pregnancy and after birth. And then, before we knew the trial outcomes, what we had were our 7 areas in the columns. So the Excel spreadsheets were huge because we collected a lot of data. But then, when we constructed our model, and once we knew the trial outcomes, we were able to group the columns according to those columns where breastfeeding rate, those areas where breastfeeding rates went up, and those areas where breastfeeding rates went down. And so in our Excel spreadsheet of all of the qualitative, summaries of all the qualitative and quantitative data, we were able to notice patterns and themes. So we found that in the areas where breastfeeding rates went up, the organisations were quite stable and very efficient in the way that they were working, whereas in the organisations where breastfeeding went down, or the areas where breastfeeding rates went down, there was a lot of change going on, both in primary care and in the maternity hospitals. So, for example, closing small maternity units and building a brand new unit, an organisational change like that could have a big impact on a trial. So, in areas where breastfeeding rates went up, staff shortages, low morale and stress were not very often mentioned, whereas they were frequently mentioned in the areas where breastfeeding rates went down. There was more skill mix in the areas where breastfeeding rates went up, and this included things like peer supporters, nursery nurses being incorporated into the team. Midwife involvement was low overall in the trial, but it was a lot lower in the areas where breastfeeding rates went down. And in the areas where breastfeeding rates went up, the health visitors were visiting more women at home, whereas in the areas where breastfeeding rates went down, they said they had no time to do that. So moving on to the next tier. Communication and team attributes. In the areas that went up, this is an example of a quote from a health visitor. We really enjoy the groups, and I think professionally it's really enhanced our knowledge because we've learned so much from the women. So here you see partnership working between the health professionals and the women, sharing knowledge. In areas where breastfeeding rates went down, here's a quote from a midwife and a health visitor. There's not much time for communication. There are so many different things going on. So the managers, as I said, this was really pivotal. And I conducted the qualitative interviews at the very end of delivering the trial. And the first question I asked was, how has the big trial been for you and your area? And I could guarantee that if I gave you a pile of those interviews, that you would only need to read the first page and you would be able to sort them into the areas where breastfeeding rates went up and those were areas where breastfeeding rates went down. They were so telling. So this is more or less the first sentence of these interviews. So a manager from an area where breastfeeding rates went up, for us I think it's been really positive. It's raised the issue of breastfeeding on the agenda as something that midwives and health visitors need to do jointly. Partnership working, a real can-do attitude. A manager from an area where breastfeeding rates went down, sorry to start with the negative stuff, staffing shortages, caseloads, operational difficulties in terms of actually covering the groups. So you get this sense of a can-do organisation and one that is really struggling. So up to the next here. You may remember that we incorporated multidisciplinary steering groups to meet every month to reflect on how the trial was going in their area. So they were asked to conduct these monthly, and so we should have expected 52 group steering group meetings in the 4 areas where breastfeeding rates went up, and the actual number of steering group meetings was 45. But you can see in the 3 areas where breastfeeding rates went down, the expected number was 39, but only 19 steering groups for reflective practice actually took place. The meetings were cancelled, nobody turned up because they were all so busy, the management was dealing with how busy they all were, and so you're beginning to get the picture here. And then the top level, the reflective, yes, sorry.
How can you have a different expected number in an RCT?
In an RCT?
Yes.
What I've done there is, this is retrospective looking back. So
No, but this was an RCT, so they had to have an expected the same number. They had to have a predefined number of interventions. So how can this differ?
Yeah.
And
because with a cluster randomised control trial, everybody needs to be at the starting post at the same time because we were using routinely collected data. Yes? So we were saying that between 2004 and 2006, that's before the intervention, between 2006 and 2008 is after the intervention. So there was a start date on the 1st of October, I think it was, I can't quite remember. But of course, in reality, what happened is that not everybody started their breastfeeding groups on the 1st of October. So it's really difficult with a cluster randomised controlled trial to get primary care organisations covering quite large geographical areas all to the start date at the same time. And that's why the expected number is slightly different between the two, because some groups started slightly later.
But how could the groups have different numbers of people?
Sorry, which
You
groups?
said that before, in one you had not the same number of midwives and health visitors coming to people. How can that be improved for RCT?
Because it's a randomised controlled trial of a policy. It's not a randomised controlled trial of breastfeeding groups compared to postnatal groups, in which case if you've done a randomised controlled trial where the intervention was breastfeeding groups and the control group was just general childbirth groups, you would have needed to have equal numbers of midwives and health visitors in each arm. Yes? Because you're matching. But this isn't a randomised controlled trial that answers the question, do breastfeeding groups increase breastfeeding rates? It asks the question, does a policy of providing breastfeeding groups improve breastfeeding outcomes?
But then why is it an RCT and a reservation control group study?
There's a strong argument that if you randomise a policy, that it will produce more robust outcomes than if you just do an observational study. If we just did an observational study, we would not have been able to come up with the explanatory model that we did, because it's a less robust design. You're not randomising. Anything that randomises...
So the policy was not on UK level. You just wanted to see if you gave those one sector, one policy, and the other ones remain the same.
Yes,
so
it's the policy, and that's why the sample size is 14. Yes, and that we did a sample size calculation, and that produced was a sufficient sample size to have 90% confidence, to have a clinically significant difference, which we chose as 6% increase in breastfeeding rates, which was the percentage that we needed to reach the target that the government had set for breastfeeding rates. So we did, I think you've had the paper circulated, so you can read the sample size calculation and justification. So it is quite a different question. It's a very, quite an unusual trial. I think it's one of the first randomised controlled trials of a policy. What normally happens in real life is that a government or UNICEF, for example, decides that the policy will be to provide breastfeeding groups. And they don't, all they have is observational evidence to support that. And what we know from policies is that quite often they have unintended consequences, or quite often the policy doesn't work. And that's exactly what's happened here. Because the policy for providing breastfeeding groups has shown no effect, we have basically saved our National Health Service an awful lot of money in setting up breastfeeding groups that wouldn't have any impact on breastfeeding rates.
But how can you claim that if you didn't provide the same sources to the regions that had to implement the policy? So was the policy only that they should have group interventions, or was it on how often should they be held and similar things?
I take your point. I mean, if we'd had lots of money and we'd been able to provide all of these areas with really comfortable venues, with adequate staff, and if we'd been able to, just give them a big bundle of cash, basically, and say, do this trial, it would probably have worked in all areas. Yes? But we did a cost-effectiveness analysis, and that's not real. The National Health Service cannot afford to do that. And if you start looking at cost-effectiveness then, it becomes unviable. And the opportunity costs, if you understand opportunity costs, it's if an organisation is putting a lot of resources into delivering one very expensive intervention, what does it have to stop doing in order to provide that? And one of the problems that we thought was occurring in the big trial was that actually we were taking the midwives and health visitors away perhaps from more individual support for women, and that could have been another reason why the trial didn't actually work, because there was insufficient staff to actually be involved in these groups. I mean, they're very good questions, and it is important. But there's quite a strong movement, certainly in the UK, that government policy should include more randomised controlled trials of government policies, because we've done lots of things in the UK that haven't worked. The classic example is teenage pregnancy. We spent an awful lot of money putting educational programmes into schools to educate teenagers not to start a family early. And it backfired completely.
I think you should talk to our Minister of Science, because he doesn't believe that.
But, I mean, well, I think that we're recognising it increasingly in the UK. What you need to be able to do these sorts of trials is very robust, comprehensive, routinely collected data. It's really difficult to do a randomised controlled trial of a policy unless you've got high quality national data. You can't do it. But if you have got that data, which we've got in Scotland, our data is 95% complete, it's very robust, we've been collecting it for 15 years. You've got this opportunity that you can introduce a policy in a randomised way, and randomising will always, always, always give you stronger evidence. Although I'm a qualitative researcher, I would always argue that. Does that help to clarify?
Yes.
But it's very pragmatic, because this is real world science. It's not ivory tower science. It's not the usual randomised controlled trial where you tightly control the intervention and you don't take account of the context. So if you remember in Fiona's slides, she had her quantitative and her qualitative, and she said that the quantitative didn't take account of context, and the qualitative as being embedded in context. And I'd argue argue that this is where the dualism of quantitative and qualitative becomes far more integrated and grey. And it's very important to understand this. So our conclusion was that breastfeeding groups increase breastfeeding rates in some places and not others. That qualitative and mixed methods explained the observed outcomes. And that an ecological systems model shows how you can optimize health services and the organisation to facilitate an intervention working. So in the areas where the organisational systems were more ideal, the breastfeeding groups worked. Any further questions? Because I'm now going to move on to a completely different trial, which has been informed by this research and is our latest piece of work. Any more questions about the big trial? So this is moving on to the FEST feasibility trial, and it's to assess the feasibility. Note it's not a pilot trial, so we're talking about flexibility here. To assess the feasibility of implementing a dedicated feeding team on a postnatal ward to support breastfeeding. So here we're learning from the big trial that actually you need teamwork and strong teamwork. We're also learning from the big trial that actually expecting everybody to be able to deliver high quality care is perhaps a little bit idealistic, and that maybe having a team where you've got a mixture of skills and strengths to focus on breastfeeding might be more effective than just letting all the health professionals support breastfeeding, or just having that single breastfeeding expert, which, if you remember, didn't work in the preliminary study. And then to pilot the effectiveness and cost effectiveness of continuing proactive or reactive telephone support after hospital discharge. There's an increasing body of evidence that suggests that proactive care is more effective than reactive. By proactive care, we mean that somebody telephones the woman and says, how are you getting on? By reactive care, we're talking about the woman saying, I've got a problem, I'm going to ring up somebody and ask for help. The systematic review evidence suggests that proactive approach, particularly for more disadvantaged women, is more effective. So again, we use the participatory approach, but slightly different from action research in that it was slightly more controlled. And we embedded a pilot randomised controlled trial, so an exact replica of what we thought our main trial would look like, within a before and after cohort study. So we're really mixing methods here. And we've got health economics in, we've got cost effectiveness, and we've got a mixed methods process evaluation. So the trial participants, we have in the hospital, in the maternity hospital, we had 2 postnatal wards. We tossed a coin to decide which ward would be the setting for this pilot trial. Our funders wanted us to target the intervention to the most disadvantaged women, women living in the more disadvantaged areas of the population, because the more disadvantaged women are the least likely to breastfeed. So our funders insisted on that. I have to say it was highly unpopular with women who felt that every baby matters and that women should be entitled to the support wherever they lived. So we excluded women who lived in the richer, more affluent areas. We also, because it was a telephone intervention, we did have to exclude some women who didn't have sufficient English language. So, do you remember I said before, you need to have the fixed components of your trial so that it can be precisely replicated when you do your definitive trial. So we decided to fix these aspects. We'd have a feeding team on the ward from 1 p.m. to 8 p.m, 7 days a week. The feeding team would be asked to watch a complete breastfeed and be with the woman to help with the positioning and the attachment to ensure effective milk transfer. We didn't provide any additional staff training over and above what you needed to work in the hospital on a postnatal ward. We asked them to provide woman-centred care because the meta-synthesis by Virginia Schmid suggests that that is more effective. And women immediately after hospital discharge were independently randomised by a web randomisation service. And the intervention was after they went home. They received proactive telephone calls every day from the feeding team. They could also phone the feeding team at any time they wanted to. And the control arm was reactive calls only. So the women in the control arm could phone the feeding team at any time that they wanted to. There's rather a trend in the UK at the moment that having a control group, which is usual care, is not considered as robust as having a placebo. So the ideal with drug trials is that you've got your two identical tablets, that one is the active ingredient and one is a dummy. And so we try our hardest, even with complex intervention trials, to have a placebo intervention. And that's what the reactive call arm was. The flexible components were, again, you could have this multidisciplinary steering group that met every 4 weeks, and they could decide on the feeding team roles and responsibilities, the content of the telephone calls, as long as they were woman-centred, and how the intervention was delivered, and particularly how the feeding team would integrate with the existing services. Because with pragmatic trials, you've got to acknowledge that contexts are unique. No one maternity organisation is like any other ones. They're all subtly different, and you need to think about how your intervention fits with the context. The feeding team consisted of a Band 7 midwife team leader, so this is a reasonably experienced midwife, and 2 Band 4 staff. Band 4 staff are nursery nurses or maternity care assistants. They haven't trained as nurses. They've had some fairly basic training in maternal and infant health, and they're there to support the midwives. So this is the design. It's quite a complicated design. So if you remember, we've got a before and after cohort study. So we took all of the women who delivered in 12 weeks before the intervention, before the feeding team started, and 12 weeks when the feeding team were on the ward. And you can see that at feeding at discharge, we had a good response rate in our data collection, and any breastfeeding at discharge was 69%. Before the intervention, after the intervention, it was 70%. So the before and after cohort study answered our question about whether a feeding team on the ward would be sufficient alone to increase breastfeeding rates. And we can confidently answer that it doesn't seem to have an impact. And here we phoned all of these women at 6 to 8 weeks after birth. And again, you can see that any breastfeeding at 6 to 8 weeks was 65% before the feeding team and 67% after. I haven't put the numbers on there, but we're talking, sorry, that's a mistake. I've obviously used the wrong slide here, because there is one that's got the numbers. But we're talking about, I think, 250 women before and a similar proportion afterwards. It's in the paper, which you've got. But a reasonable number, reasonable cohort, and quite acceptable response rates to the outcomes. So then we embedded our randomised controlled trial within the after component of the cohort study. Remember, it was women in disadvantaged areas only. We had 113 women who were eligible, who lived in disadvantaged areas, and 69 agreed to participate. We collected information on women who chose not to participate. Some of those didn't have very good English, but the vast majority were having their second, third, fourth babies, and they'd already breastfed and said, well, I haven't got any problems, I don't think I need a telephone intervention. 35 were randomised to get the proactive course, the intervention, 34 in the control group, and we managed to follow up 91% in the intervention arm, but there was some loss to follow up in the control arm. And some of that was around these disadvantaged groups running out of mobile phone credit and changing their telephone numbers. And so that is a slight problem with this pilot trial. So I'm going to focus now on the process evaluation. This is quite important. If you're doing a randomised controlled trial, you need to balance any qualitative data that you collect between the before and the after, and also between the trial arms, the intervention arm and the control arm. So if you're doing qualitative interviews with women, you either need to do them after the woman has exited the trial, so after the 6 to 8 week outcome data, or if you do it during the trial, you need to make sure that you interview 12 women in the control arm and 12 women in the intervention arm. Otherwise, the qualitative data collection interferes with the integrity of the randomised controlled trial. You need to give an awful lot of thought to exactly how, as qualitative researchers, you could be interfering with the robustness of the trial design. So, really important point. And my preference is always to do interviews after trial exit, both with staff and with women. So here are our primary outcomes. And the findings didn't reach significance, but we didn't do a sample size calculation because this is a pilot trial. The whole point of this pilot trial is to enable a robust sample size calculation for the definitive trial. But we had a 22% increase in breastfeeding outcomes, any breastfeeding, at 6 to 8 weeks after birth, and a similar increase in exclusive breastfeeding, 6 to 8 weeks after birth. And so we're hoping that this data is convincing to our research funding body, and we've put in an application to do a 10-centre, multi-centre randomised controlled trial of this intervention based on this, on this pilot study. But I now want to go on and talk about the process evaluation. So we collected quantitative data for the 35 women in the intervention arm. The women had, on average, 8 calls. These are medians with interquartile ranges. A median of 8 calls. And it was a woman-centred approach, so a woman could choose if she wanted to stop the telephone calls at any point. And some women did because they weren't having any problems with breastfeeding. Or some women did because they'd actually stopped breastfeeding, they'd changed to formula milk. There were about 3 attempted calls per women, where the feeding team member couldn't get through to the woman, it was engaged or no answer. The successful call duration was 5 minutes, which was actually a lot shorter than all of the staff expected. They thought that telephone calls might go on for a lot longer. 3 women stopped calls before day 7, and 20 stopped the calls before day 14.
I just asked, what was your intention of calling how many times? If we have 9 interquartile, does that mean more than once a week you wanted to phone them?
We're phoning them every day for the first 14 days. So, and then the calls stopped. After 14 days, the calls just stopped. And the basis for that is that, as I explained, in the UK, 20% of women stop breastfeeding in the first 2 weeks. So our hypothesis is if you can stop that steep decline in the first 2 weeks, then you're going to have more successful and it's also a pragmatic intervention in terms of And you need to make this cost effective in the current fiscal climate, in the current economic climate. You cannot deliver an intervention that is just too expensive for anybody to consider rolling out. What was really surprising is that in the control arm, only one woman called the team, and her call lasted 8 minutes. This was a complete shock to everybody. They presumed that women would be phoning all the time. And this is probably quite important because we have a lot of helplines for breastfeeding in the UK, and people are quite busy on these helplines, but it would suggest that actually it's your more advantaged, educated women who are actually phoning up and asking for help. So why didn't women phone? Women found it very difficult to articulate why they didn't phone. They sort of went a bit quiet and said, I don't know. And there was well, it's my fault, I should have phoned. And that was a common reaction to when we asked. Some women said they just felt miserable, they felt exhausted after and overwhelmed after they had the birth of the baby. Some women just said, well, I forgot. Some went out of phone credit because these were disadvantaged women, and some women had no problems, so they felt they didn't need to phone. They had enough support from their mothers, their sisters, their friends. The other thing is that they perceived the midwives and health visitors as being really busy. They undervalued breastfeeding as a reason to seek help. And they also undervalued their own needs compared to the needs of other women. So the proactive daily phone calls, there was a real strong preference for this. There wasn't genuine equipoise here. And they found the calls reassuring. They knew that somebody was going to be phoning the next day to hear about the dreadful night they just had. And it was very woman-centred, so the women were able to say, oh, I don't want to speak to you today, but please phone tomorrow, I'm busy today. So it wasn't, that woman-centred approach was very, very important. The non-randomised women, the women who didn't want to be randomised into the trial, felt that the calls might be a bit disturbing. What happens if I'm asleep? I don't really want somebody phoning me up if I'm having a nap. And they didn't perceive any need for the calls. And we recorded calls, so we were able to find out what was going on in these telephone calls. And what was fascinating is that the word breast was seldom mentioned. The feeding team referred to it as, how's the feeding going? It was all about feeding. So very woman-centred approach. It wasn't, how's the breastfeeding going? So you're never making that assumption that actually the woman is still breastfeeding. It wasn't promoting or pushing breastfeeding at all. It was a feeding team. That is so important. Took all the pressure off. There was continuity of care, so that the women had established quite strong relationships with the feeding team on the postnatal ward. They used very lay language. There was lots of affirmation. You're doing great. That's fantastic. Asking what's working best for you. And women felt cared for. They didn't feel it was being promoted and pressurised. It was very unrushed. They felt that the staff had time for them and focus on women's well-being. And here a woman says, a lot can happen in 24 hours, you know, in terms of how he changes his feeding and stuff. So it was good to sort of sound off with somebody and have an opinion back on what you should try this time, and maybe try this tonight and see how you get on tomorrow. And this is particularly true of women having their first babies, who perhaps didn't have a mother or a sister who'd breastfed. It's very important. And so the implications of this piece of research is that proactive daily phone calls delivered by a dedicated feeding team, which requires no additional training at all, can improve breastfeeding outcomes for a very small additional cost. And in the papers that I've circulated, the cost effectiveness and health economic analysis is presented in that. But person-centred communication is really important, and now we're going on to do a definitive trial. And Charles Darwin was the first to observe that for all animals and human beings, I would argue, that in evolution, division of labour is inevitable for survival, and that specialisation can actually improve performance. And so we feel that actually possibly it's unrealistic to expect all doctors, all midwives, all health professionals to be able to support a very complex performing skill like breastfeeding. And maybe we should be thinking more of dedicated teams. On the way forward, in conclusion, for complex interventions, is trying to understand the organisation and context factors that enable an intervention to work. There are questions about to what extent you try to optimise the environment where the trial is taking place beforehand, because we've got lots of examples of randomised controlled trials that work under ideal conditions in a research environment, but then when you come to translating them and implementing them in real life, they don't work. And it's really important, if governments are to spend limited resources effectively to change lifestyle behaviours like breastfeeding, smoking, obesity, that actually we have really robust evidence to support this. And I would argue, therefore, that randomised controlled trials policies are really crucial to get this high quality evidence. Local action research approaches can work, because obviously you cannot do a randomised controlled trial for every single research question. You've got to really pick those questions which are answerable, and I would argue that answerability depends on really high quality, routinely collected or cohort data. It's crucial. The data collection at national level is so important if you want to have a robust evidence base. And I would argue that actually we've conceptualised trials as interventions, the now, the thing. I would argue we need to think much more about complexly intervening and about trials as complex adaptive systems, because context and intervention are actually integrated. We're not dealing here with the nice, neat, randomised controlled trials of drugs, active component, placebo. That's easy. This is much more about complexity. And I would argue that qualitative research can add value to understanding all aspects of a randomised controlled trial, from recruitment right the way through to understanding trial outcomes. Thank you.